review what your understanding of your father's prognosis is and the diagnosis and all of that.
Great. First question, I think it will be helpful for you to review that with all of us. I know my sister and my mother heard it, so we got some information from my sister.
Right.
But I think it would be helpful to start there.
Okay. So I would like to hear what your understanding is first, before I go into more detail.
My understanding would be it's a certain type of cancer. There's the astro, whatever, type 2, but when you go down to the molecular level, it's more of a glio type of diagnosis, which is far more aggressive and widespread.
Right. So that's pretty much it. When we take a piece of it, it looks like a grade 2, but in the context of how widespread it is on the MRI, it's spread pretty far. It's not just in one small spot, which is what we normally see with low-grade gliomas. Usually low-grade gliomas, they're small enough that we can actually take out almost everything. But the fact of the matter is it's not behaving like a typical low-grade. Whatever it is, it came on very, very quickly. It seems like he was normal not too long ago. And based on what we call the molecular sequencing panel, which is when we take the tumor and look at the genetic abnormalities, the mutations in the tumor favor more of a glioblastoma-like picture. So the prognosis is not as good as a typical grade 2.
Mm-hmm. So obviously there's no operation that can be done. Is there any chance chemo or radiation would help at all?
It depends on, whether or not we establish the goals. So,
Hi,
this
I'm
is
Dr. Shukla. I work with Dr. Barad.
Hi.
We met briefly. We chatted on the phone. Hi.
We did on the phone. Nice to meet you. Hello.
Hello. This is one of our senior doctors, Greg. He's
Hello.
also working with us this week. Sorry to interrupt.
that's okay. So the standard of care for high-grade gliomas, because we're going to treat this we're going to approach this like a high-grade glioma. The standard of care is a combination of radiation and an oral chemotherapy called Temodar. Typically, we give radiation that's limited to the disease site, just to minimize the cognitive side effects that are associated with it. But because we see a good portion of tumor that's starting to spread towards the left side, if we are to actually hope to preserve or keep things from progressing, I would recommend irradiating the entire brain.
Mm-hmm.
The standard dose that we give, which is 55 to 60 gray for these types of tumors, can't be done as whole brain. It's just too toxic. So we would be giving about half the dose.
It's effectively a little bit more than half,
Okay.
because the standard dose that you give each day for the 6-week regimen is a little bit less. When we give a little bit more each day, we can shorten the total duration of treatment and give a little bit more dose each day. So the typical regimen that we would do would be 30 gray, which is the dose of radiation, the units is gray, and then it's delivered in 10 treatments. So you give a little bit more each day. And that is typically offered in this situation, like Dr. Martinez mentioned, where we see infiltration of the tumor to the other side, potentially infiltrating in more than what we can even see on the scans.
Do you think he can handle this?
That is a very good question. In order to be able to get radiation safely, he'd need to lay flat in a table so he can get radiation. But he's going to be alone in that room. If he's disoriented and he tries to come off at the table by himself, it could be very unsafe.
The way that we set up the treatments for radiation, the patients will wear a mask that immobilizes their head. And as long as they're aware of that and understanding of the whole process, it's very well tolerated. But it's attached to the table so that their head isn't moving into the areas of high dose of radiation.
Could he be given a sleeping pill so he could sleep through the procedure?
He can be given sedating medications, potentially.
He's better without medication.
Some of the issues are that those sedating medications can lead to other complications or side effects, making people more drowsy, as he's been dealing with over this week as well. So we worry about giving some of those medications to patients routinely for treatment. In rare cases, we can do things like put patients under general anesthesia, but I don't know that the benefit risk in that situation is really helping us at that point either. So that would be a more challenging situation.
I guess what has been your success rate with patients like him, given his age and
It's hard to say.
his disease?
Some patients will have a response where they'll have some symptomatic improvement. Some patients will not. And so they'll maybe have some side effects from the treatment, but not significant improvement. When the disease is infiltrative and extensive, like we see in Mr. Cole, then it's hard to really predict how different patients will respond.
Side effects
It's tougher.
in terms, like, maybe,
The biggest side effects will be a little bit of hair loss, tiredness or fatigue, some nausea is possible, and some patients will get like a sore throat, temporary.
just during the treatment
Temporary
period.
during the treatment, maybe the week after. Those are all temporary. The hair loss usually comes back within 6 months, if not sooner. Not always, but usually. The nausea is temporary, can be managed with medications. The fatigue goes away also. The radiation-induced fatigue gets better after you're done with treatment. There are long-term side effects like cognitive changes, things like memory, short-term memory loss can be impacted by whole brain radiation treatment. Doesn't
How's
happen.
that now?
Doesn't happen to everybody. If people are starting with some difficulties there, it can get worse, and not always reversible.
If he did nothing, what would be your projections?
So I don't like to use the word nothing. We will definitely recommend measures that are supportive to help him feel as well as he can. Whether those are directed towards the cancer is a different question. So we're talking about anti-cancer treatments like temozolomide and radiation treatments, which may also help him have some benefit or duration of feeling as well as he can.
So I'm a little
May not.
confused. Someone posed the question to my mother the other day. Would you prefer to do nothing and just?
Yeah, so the term nothing comes up as potentially a term that means non-cancer therapies. But that doesn't really mean nothing. It means medicines like steroids or other symptomatic treatments that can help him
But
be
it
as
doesn't stop
energetic
the
as possible.
progression
But
of
they don't work
disease.
against the tumor
They don't
cells.
work against
They just help with
what's happening.
symptoms.
What will be your collective recommendation?
Dr. Martinez?
So we have to take this into the context of what could we potentially gain from treatment and weigh them against the potential risks of treatment. So in my experience, this type of tumor is very hard to control. Even if we can get some stability with treatment, the stability doesn't last very long. In a couple of months, it tends to progress through treatment. If we were to change the direction of treatment from directly treating the tumor and trying to stop the progression to making sure that he's comfortable, we could be looking at probably less than a year, maybe more like 6 months.
Mm-hmm. And that's 6 months. What would that progression of that 6 months look like?
Primarily behavioral changes at first. He may be more impulsive, or he may seem more sleepy. The question I always get is, what does things look like towards the end? And it's usually, we usually see people not have an appetite, they don't feel like eating. And so just eating things that give pleasure are fine. It's not necessary to force food or water or anything. Certainly if there's an infection, it would make sense to treat it. But generally we focus the management on making sure that things are comfortable for him.
Mm-hmm. So, one final thing, I'm sorry. So effectively you're saying that the success rate for whole brain radiation of a tumor that's this widespread, and this aggressive, is pretty limited, and we would be putting him through a lot for a really low success rate. Most likely, it's gonna come back. That's
Right.
We won't get much more time in doing that.
May not.
But if
May
we
not.
did, let's be hopeful. You're saying a few more months before it would come back, and if it were to come back, would it be the same course of treatment again, or do you not do treatment the second time
Well, it
around?
depends on how it comes back and how he looks. We would definitely consider things that he could tolerate. If he is able to process information, and this is very unlikely, but potentially if there were a clinical trial that were available, we could discuss that. But we don't have any right now,
That was my
mainly
next question.
because it's so widespread that effectively excludes him from any of the clinical trials we have available here.
Here, or do they have things elsewhere?
For gliomatosis, the clinical trials that are available are rare, and they are not in this area.
John
I
Hopkins?
don't know of any that are actually open. It would be very difficult to find a clinical trial that would not exclude someone like him because his performance status is so low. For most clinical trials, you have to be able to understand the treatment that you're getting and walk, tolerate all the visits and treatments. And most patients with gliomatosis can.
Would you suggest, I don't want to talk about a holistic approach, but have you ever seen any other type of treatment options in combination with chemotherapy and radiation that could be potentially successful, that he could also be given as well?
I have had one patient that tried CBD oil.
Is that the Simpsons oil or something like that? Is that what that's called?
I'm not sure.
Okay.
Maybe.
I know what you're talking about. And what was that?
So that's basically cannabinoid.
Yep, I know it.
So I haven't had any experience before that, but if anything, it may have given him some comfort, but it didn't do anything for his tumor.
Because it seems like a dire straits type of situation, so I think it would be helpful if we collectively, just gather as much
I'm not aware of
information
any evidence either
as we
that
could
been
help
shown
him.
to, prospectively been shown to
Right.
help, other than the anti-cancer treatments that we've talked about, the drugs and the radiation treatments.
The only treatment that we have available that is standard of care for newly diagnosed glioma is radiation and chemotherapy with temozolomide. At recurrence, there is another drug that is FDA approved for recurrence, but it is beneficial mostly when there is a lot of enhancement on the scan, meaning there's contrast uptake. But on his scan, there isn't much of that.
Have you seen a difference between the MRI that was recently done compared to when he entered the ER 3 weeks ago? Have you seen much of a difference in progression in 3 weeks that you're aware of? Because I know he's had several.
From the standpoint of radiation planning, we would treat the entire region just because of the extent of disease extending onto the left side. There wouldn't be much for me to spare. In terms of change from the initial baseline,
I guess I'm trying to.
I think you're trying to
Figure
ask
out
how fast is
Right,
this growing.
right.
I didn't appreciate a significant change. But that doesn't mean that there's microscopic disease that's not there. Because there could certainly be tiny tumor cells that aren't just showing up on the MRI just yet.
Are you surprised at all? I think Judy was surprised at his level of function coming in, considering how widespread that he saw it. Or is that surprising at all, given his current condition? I mean, or is this about right from what you see?
But if I'm focusing on his mental status, on his cognition, I'm not surprised.
Okay.
And we say that because, you know, two of the neurosurgeons, Judy and even Dr. Farrell, said that looking at his MRI, you wouldn't expect this to be the patient,
Right.
given his response and just still, you know, how he's reacting. So I know there's an assessment based on data and information, but then clinically, what you see as well.
Right.
Could there be a disconnect there? I mean, is there hope that he can still...
Is he right or left-handed?
He's right-handed.
And I think that could explain why clinically he looks so much better than his scan. Because in right-handed people, the brain on the left side predominates most of the functions. So I think what we're seeing is the functions on the right don't have as much clinical sequelae compared to if he had these similar symptoms on the left side, if that makes any sense. But nevertheless, the right side, the frontal part of the brain, is responsible for important things like executive functioning. How can you balance a checkbook? Can you plan your day? Can you organize your thoughts? And that's being affected.
What happens if we don't do the chemo and radiation? Where does he go? Does he go home?
Then I would ask for the assistance of the palliative care team who can help arrange the next steps. If he wants to go home instead of rehab.
I don't want him to go home and die. He's got to have a chance. Just a chance. I'm just not sending him home to die. A little chance. Just try it for a while. See if anything's working. If he can't take it, it's a different story. But I just don't want to throw in the towel.
Okay.
Does he stay here? What happens if we do the chemo and radiation?
Well, the chemo can be taken anywhere. I think they can administer the chemo in rehab. The question is,
The radiation
can
treatments
be
are done in
there?
our department, which is just downstairs from where we are now.
But the
In
question
theory,
is,
it can be done as an outpatient if a patient is at home also, just requires transportation.
He's not in
So
a
right now we
position-
can't.
That's not really feasible at the moment, so if he's at the rehab facility for a period of time, we can certainly start the radiation treatments while he's here, see how he does, and then make an assessment as we go. We would probably prescribe something like 2 weeks of treatment. You had talked about possibly adding the temozolomide while we're
We can try the temozolomide
here and
if,
see what happens.
yeah, if he's able to swallow the pills whole without problem, then we'll continue it.
And the radiation is a 2-week period?
Yeah, there are different regimens that can be done. There's a 1-week regimen where we give an entire dose over a period of 1 week. That can make people really tired, like even more than the 2-week regimen does. And then there's a 3-week regimen, and then there's also the 6-week regimen. I think for him, Dr. Barad really wants to try the whole brain treatments for 2 weeks, if that is the decision of the group. But again, she's also very understanding of wanting to make sure that we're taking the appropriate
And this is
risk and
assuming
benefit.
he can lay there and do the treatment?
Yeah.
Well, that
Yesterday he suggested that he would be up for it. Every day he's different, and so we would have to see each day and see how he does.
Rehab indicated right before we came in here that if they don't see progress within a certain amount of time, they're going to discharge him from here to go to a level down facility where he won't get as much treatment on a daily basis. Again, if he can't walk and he's not here, then how does this get done?
There may be transportation options available from any facility. I would have to look into that. I'm not sure what the time course is that the rehab doctors are thinking about, so I would try to talk with them and see what their goals are and what their plans are before we started anything, and then we can lay out a plan for that.
She also mentioned that they would do the therapy in the morning and do the radiation in the afternoon.
Yeah.
This way he could rest the rest of the day.
But and just to add to that, if if he's in rehab here
Mm-hmm.
and he starts rehabilitation therapy in addition to radiation therapy, and they decide that he's not progressing as well as he should,
Mm-hmm.
and want to downgrade him to a subacute unit, but he's already started radiation, how does that affect his treatment?
I mean, we
Yeah,
would have to
potentially.
figure out a way to logistically make that work out. The treatments themselves don't last very long. You know, you'll spend more time transferring from Thompson to our department and back than he will actually getting treatment. And if he's further away, then he'll just spend more time in the transport.
And if he's doing a lot of rehab in the morning, is that gonna make him too tired? Like, will he rest in between rehab
Yeah,
and?
get some time to rest.
Because
And the treatments themselves, again, are not, the difficult part is in the moving around from place to place. The treatment itself is an x-ray. You don't feel anything or see anything happening during the
How long does he
radiation
have to lay
treatment. So
still? How long is it?
15 minutes or less, 10 minutes.
But is it a treatment whereby once you start, you have to continue each day? Like if
Yeah.
he were to get,
Yeah, I wouldn't want to start a 2-week regimen
Right.
and then have to stop after 3 days.
so that's something we would have to agree to
Yeah.
with the rehab doctors.
That's why I want to talk with the
Right.
rehab team to see what their intentions are and what their anticipation is.
Because I would think that we would want to start this sooner rather than later.
Is Caitlin aware?
Right.
From our standpoint, we can bring him for a mapping session tomorrow, potentially, and then start the treatment shortly thereafter. What is today's Tuesday? Today's Wednesday. We could probably start either tomorrow or Friday, otherwise latest Monday morning or Monday afternoon to start the radiation treatments,
What do you
if
do?
that was a decision.
Do you do an MRI 2 weeks from now and see what the impact is? How do
Usually
you
not.
assess?
Usually we wait about a month or so after completion of radiation for any of the inflammation and treatment effects to kind of fade away. And then the scan gives us a new baseline. We don't always see a big change or a huge response in the first scan right after the treatments, but it's really designed as a new baseline that we then use to compare how things are going in the future. If we see, large growth of tumor at that 1 month checkup, then that suggests that the tumor was not really responding to the treatments that we offered. But otherwise, if we see it relatively stable or maybe a little bit improved, then we use that as our new baseline marker for
Got it.
subsequent scans.
Okay. And just so I'm clear on the diagnosis, because everything I've read has been sort of the, pardon the pronunciation, but the astro or the glio. This case is such where it's so widespread, it's got elements of both of those, and considering at the deeper molecular level there's glio, therefore it's treated as glio. Is that a fair?
I would say that
I mean, is there one name that speaks to his condition? Like one,
so the terminology is changing based on how much we know what's going on genetically in the actual tumor's DNA. So we used to call this gliomatosis cerebri, but now that we're looking more at other elements in the tumor's mutations, we would probably now just call this a diffuse infiltrating glioma without any mention of the grade. So it's not like a glioblastoma in the sense that it's using up the blood supply and picking up contrast, but it's aggressive in the sense that it wants to spread.
anyone that I've ever known that had a loved one have the glio basically said it was a tough experience. So I'm wondering. I'm just wondering how this could potentially play out. So it has attributes of the glio, but there's parts that it doesn't have that level of attribution.
Right, so it's aggressive like a glioblastoma.
Yeah.
That's how I would put it.
Okay, got it. But there's not one specific term that you would associate with his specific prognosis.
I agree with
correct?
Dr. Martinez, diffuse infiltrative glioma, meaning a tumor that comes through the brain cells
Yeah, that.
and is
Okay.
infiltrating throughout multiple regions of the brain.
How often do you see that particular
It's
condition?
not as common as the glioblastomas that you were referring to a moment ago. It's less frequently seen.
And still no idea where this could possibly come from?
Usually sporadic mutation.
If it's so rare?
It's not clear that there's an etiology.
I mean, there's nothing that he did or was exposed to that could have caused this that we know of. We still don't know why.
Mm-hmm. Well, considering it's rare, it probably makes sense to try the chemo and the radiation. I mean, who knows? You probably don't have as much of a data set on this type of condition than some others, right?
There is some data. There are some data sets, and in the days when it was called gliomatosis, the whole brain treatment has been used, and we have had some patients that have had response. There are some factors that are in our favor, right? The specimen that was taken out during surgery was not as aggressive as a, grade 4 glioblastoma might be.
Mm-hmm.
But the image, as you referred to earlier, looks a lot more aggressive than even he appears clinically. So it's hard to know exactly whether he fits into all those old data sets that have been used to show that some
Right.
patients benefit from whole brain radiation and some may not.
And when you talk about aggressiveness, and again, forgive me if you've already mentioned this, but are you talking about, again, seeing something when it comes to data that you're looking at, or kind of a projection of how long it's been going on? Like, is it possible that this has started last year, and over time, it's gotten this big? Or do we know with some certainty that this probably started a couple months ago?
There's no way to know when it started or how long it's been in his head unless there was an MRI or some other similar scan done recently before all of this. So I really don't know. It may have started out with a dot that just didn't transform until years later, or it could have started just now. I don't know. But I don't think that changes what we would do for it.
Right, I understand.
Are there effective ways to keep him comfortable without just dumping morphine in him and then his lungs stop? I went through that with someone else already.
Yeah. We have new approaches to keeping someone comfortable. May or may not require an addition of medication, but morphine is not the only medication we have in our toolbox these days.
Mm-hmm.
And what's the genetic relationship, if anything? And I ask because my husband's father died of a glioblastoma.
Yeah.
And now my father, it doesn't seem to be as rare to me, obviously. Now I have 2 family members with this condition.
So who else?
My husband's father, and I have 3 small kids. So is there a genetic component to this?
So it's not hereditary.
Okay.
There are some forms of gliomas which are hereditary, but they're usually in the context of cancer syndromes, people that have other tumors in addition to a glioma. Those are hereditary, but unless you or your children have been diagnosed with a hereditary cancer syndrome by now, it's unlikely, very doubtful actually, that this can be passed along to somebody else.
Okay, because that's weighing in my mind as well. I have a 10-year-old that says she has headaches, so, is that something? Should I be scanning my kids?
Yeah.
So that was a big concern. Okay.
It's doubtful.
Okay, thank you.
So it sounds like we are looking at the radiation chemo initial path and doing an assessment, right? I live in California now, so this is a California question, and that oil is kind of, people swear by it, right? I don't know. Could you do alternative things in conjunction with this and throw the book at, try to throw the book at this thing, so to speak?
Yeah, if we have those therapies available here,
Yeah.
if he's in rehab or in a hospital, but I don't think that we stock CBD oil here, or but it depends.
Yeah.
What is that?
It's oil from cannabis, essentially, right? And evidently, people put it on
Is it
whatever.
considered medical marijuana? But that's legal in New Jersey.
Well, it's not medical marijuana per se, it's a different formula, and there's,
They take oil from the marijuana somehow.
yeah, it's not smoked, it's actually given through the mouth, or actually rectally, you can give it that way. But I don't know how strong the evidence is, but there are reports that it may have some impact on the progression of tumors like the glioblastoma. But I haven't seen any good evidence that it is very effective, that we should start introducing it into standard of care. However, if it's not harmful,
Right,
That's
we
my
have
thought.
we have nothing to lose at this point.
right,
I mean,
if it's not harmful, then, I wouldn't say no.
I'm not aware of any increase in toxicity from the radiation treatment.
Yeah.
I just don't know of any
Yeah.
evidence to that effect, so I.
Yeah, as long as the combination of the two, aren't detrimental, right?
May be helpful for nausea, who knows?
Yeah.
Yeah.
How do you get it?
Online.
Oh, you can?
I think you can get it online.
Do we buy it, or do you buy it as part of his treatment?
It wouldn't be part of this treatment.
Okay. So we can legally purchase that and bring that here?
I don't know if they can administer it here. You can bring it, but I don't know if they would be legally able to administer it.
But if it's a pill, it's something that
My
we could just do.
girlfriend's father-in-law takes it, and he's had stage 4 liver cancer, and he's lived for 3 years, and he's been using this oil, in combination with chemo and radiation. I don't know the effects, I think that it was introduced to him, and he's been doing well. Surprisingly, they only gave him 6 months, so he is taking that. I don't know. I don't think we have anything to lose, so I would consider that.
If you do get a hold of it and he's still in rehab, you would have to make sure that the rehab
Sure.
team is
Comfortable.
agreeable.
Sure.
Okay. And who would you be part of his team?
Yes.
Yes.
Okay.
I would be what you would call the quarterback, as we talked about.
Yeah. Got it. Okay.
He is a fighter, though. He's been through a lot
Yeah.
before.
I
So
know.
he's a fighter. He'll try his best. He will.
I'm sorry, what's your name?
Sure. I'm Nina Martinez. I'm the neuro-oncologist.
This is our accountant taking all the notes. What else do we know?
This is my card. You can pass
Thank
it
you
over.
so much.
I think at this point, I think I know what you would all want to do, but I just want you guys to have some time to talk it out as well, and then confirm with us, either
Yeah.
get back to him or
Of course.
get back to me.
And like I said, we can certainly
Yeah.
bring him over to our department tomorrow or Friday for that mapping session.
Well,
and
Mom is
then-
pretty adamant how she wants to proceed.
And
Yeah,
then,
there's no question.
and then proceeding with the treatments next week
Yeah.
is
How-
reasonable.
I wonder how he's gonna respond. Like, he's already tired. Well, we'll see how rehab goes tomorrow, but he hasn't been really through rehab yet, and that's supposed to really tire him. The combination of this with that, I'm hard pressed to see him having the ability to do both at a. I'm hard